This video begins with a brief overview of health history taking, followed by anatomy of the thorax, then the examination of the posterior and anterior thorax and lungs, using inspection, palpation, percussion, and auscultation. We conclude the video with tips on describing your findings. In this video, except where noted, you will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint, along with common or concerning symptoms. Common or concerning symptoms relating to the thorax and lungs include chest pain, dyspnea, wheezing, cough, and blood-streaked sputum. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. With the patient's health history in mind, you are ready for the examination. An understanding of thoracic landmarks is integral to systematic examination of the thorax. Therefore, let's take a few minutes to review these landmarks before beginning our examination. The bony thorax encases the heart and lungs and partially covers the kidneys, spleen, stomach, and liver. The thorax consists of 12 pairs of ribs, their costal cartilages, and their attachments to the sternum and thoracic vertebrae. Portions of the cartilage form the costal margins. To locate and describe your findings when examining the thorax and lungs, you must be able to number the ribs and interspaces accurately. Anteriorly, the key landmark for this purpose is the sternal angle. To find it, start at the suprasternal notch and slide your fingers downward about 5 centimeters until you feel the bony ridge that joins the manubrium to the body of the sternum. This is the sternal angle. Lateral to this angle lies the second rib. The second interspace is just below. To identify the lower ribs and interspaces by number, start in the second interspace and walk your fingers from interspace to interspace in a downward and lateral direction. Posteriorly, the tips of the scapulae are usually at the level of T7. When attempting to localize your findings, you will need to number the patient's ribs accurately. Find T12 and the adjacent 12th rib by pressing up from below the rib cage. Then slide your fingers up and over this rib into the 11th interspace. From here, walk your fingers upward in the interspaces. An alternate method of numbering the ribs is to count the spinous processes distal to C7. With the patient's neck flexed forward, find the most prominent spinous process, which is usually at C7. Then feel and count from C7 to T12. To further locate and describe your findings, use these imaginary vertical lines: the midsternal, midclavicular, anterior axillary, mid-axillary, posterior axillary, scapular, and vertebral. When examining the chest, it's helpful to visualize the underlying lungs and their lobes. Anteriorly, the apices of the lungs usually rise 2 to 4 centimeters above the inner third of the clavicle. The inferior border of each lung crosses the 6th rib in the midclavicular line and slopes downward, crossing the 8th ribs in the mid-axillary line. Posteriorly, the lungs extend from above the scapulae to about the level of T10 on quiet inspiration and to T12 on deep inspiration. The left lung is divided into 2 lobes and looks like this: anteriorly, laterally, and posteriorly. The right lung is divided into 3 lobes and looks like this: anteriorly, laterally, and posteriorly. Note that the right middle lobe underlies the axilla. Later, you will auscultate this 3rd lobe separately. The trachea bifurcates into the right and left main stem bronchi at about the level of the sternal angle anteriorly and at about the level of T4 posteriorly. Breath sounds near these areas usually have a harsher quality than those elsewhere on the chest.
Okay, I'm going to go ahead and examine your chest now. Just breathe normally for me. Okay.
Begin your examination of the chest with a brief survey of the patient's thorax and respiration. Is the thorax symmetrical? Are there any bony deformities? Note the lateral diameter of the patient's chest. Does the anteroposterior diameter seem increased, suggesting possible obstructive lung disease? In this patient, chest diameter looks normal. Observe the rate, rhythm, depth, and effort of breathing, and listen for any audible sounds of breathing that may indicate respiratory distress. Now, listen and count the number of breaths per minute. Normally, a resting adult breathes easily, quietly, and regularly, about 14 to 20 times a minute. Inspect the patient's neck for retraction of the supraclavicular sternocleidomastoid muscles, suggesting respiratory difficulty. Normally, this is not present. Palpate in the sternal notch to check the position of the trachea. It should be in the midline. Check the color of the patient's lips and fingernails for any cyanosis, a bluish color arising from deoxygenation. Lips and fingernails are normally pink, as in this patient.
Can you cross your arms for me and put your hands on the opposite shoulders? That's it, just like that, and breathe normally for me.
Have the patient place his hands on the opposite shoulders and breathe normally. Now examine the posterior thorax, beginning with inspection. Observe the chest for contour, symmetry, and deformities. Also, inspect the overlying skin.
Okay, tell me if this hurts anywhere.
Then, palpate the chest wall to locate any areas of pain or tenderness, or to assess any lesions or abnormalities you may have found during inspection. To assess lung expansion, place your thumbs close to the patient's spine at the level of T10 and spread your fingers lightly across the lateral thorax.
Okay, please inhale and exhale deeply for me.
Ask the patient to inhale and exhale deeply and fully while you watch the divergence of your thumbs and feel for the range and symmetry of movement. Next, systematically palpate for tactile fremitus.
Okay, I'm going to put your hands on your chest and please say 99 every time I touch you.
99.
Feel for the vibrations of tactile fremitus as the patient continues repeating 99, blue moon, or some similar phrase consisting of 2 or 3 equally accented syllables. Using the edge of the hand is also common. Identify areas of increased, decreased, or absent fremitus. Continue the examination by percussing the chest in a systematic manner, moving down the thorax and going from side to side as demonstrated in a ladder pattern. Remember that only the posterior surface of your pleximeter finger should be in contact with the chest wall. Wrist motion should be relaxed and fluid as you make 2 strikes with your third finger. Percuss down the chest wall from the apices to the bases of the lungs. Listen to the intensity, pitch, and duration of your percussion notes, and note the sense of vibration. Then decide what kind of notes you are hearing. Normal lungs are resonant. Locate any areas where you hear abnormal dullness. Next, use percussion to identify the level of the diaphragms and measure diaphragmatic excursion.
Now, if it's all right, I'm going to put some ink marks on your back. So breathe all the way out and hold it for me, please.
Then percuss downward from above the expected level of diaphragmatic dullness until dullness is definitely heard.
Okay.
After gaining the patient's permission, mark the level of full expiration. Next, have the patient inhale deeply and hold it in. Then percuss downward to the level of dullness at full inspiration, and mark it. Repeat this process on the other side. Then measure the distance between the expiratory and inspiratory levels of dullness. The distance is normally 5 to 6 centimeters. Let's pause for a moment and review normal and adventitious breath sounds. Breath sounds are classified by their intensity, pitch, and duration during inspiration and expiration. Normal vesicular breath sounds are soft and low-pitched. They are normally heard during inspiration and during the first third of expiration, and can be heard over most of the lung fields. Bronchial breath sounds are sometimes heard as you listen over the manubrium, and this is normal. Bronchial breath sounds are harsher, louder, and higher in pitch than vesicular sounds. They are often heard over the trachea and main stem bronchi. The expiratory sound lasts longer than the inspiratory sound, and a silent gap may separate these 2 sounds. Bronchovesicular sounds have an intermediate pitch and intensity. Inspiratory and expiratory sounds are about equal in duration, and a silent gap may or may not separate them. These sounds may be heard in the first and second interspaces anteriorly, and between the scapulae posteriorly. Let's listen to these sounds again to compare them. Vesicular, bronchial, and bronchovesicular. Adventitious or added breath sounds consist of 2 basic types: the discontinuous sounds, or crackles, and the continuous sounds, wheezes and rhonchi. Crackles are intermittent, non-musical, and brief, like dots in time. Fine crackles are soft, high-pitched, and very brief, and often accompany congestive heart failure. Coarse crackles are louder, lower-pitched, and longer. Compared to crackles, wheezes and rhonchi last much longer and sound more musical. Wheezes are relatively high-pitched and have a hissing or shrill quality, and often suggest asthma. Bronchi have a lower-pitched, snoring quality and suggest secretions in large airways. To auscultate the posterior thorax, use the diaphragm of the stethoscope. Begin at the apices and proceed downward, moving systematically from side to side, again in a ladder pattern, comparing breath sounds in symmetrical areas. Listen to the duration, pitch, and intensity of the inspiratory and expiratory sounds. Decide what type of breath sounds you are hearing, and note any added sounds. Listen to at least one entire breathing cycle at each location.
Take deep breaths in and out with your mouth wide open, please.
During auscultation, have the patient breathe deeply with his mouth open. If the patient becomes uncomfortable, allow a rest period. If you hear bronchial or bronchovesicular breath sounds where they should not be, listen for transmitted voice sounds. While auscultating the chest, again ask the patient to say 99.
Say 99.
99.
Voice sounds that are louder and clearer than normal, as in this example, are called bronchophony. Next, have the patient say E.
Say E, E, E,
E, E.
When E sounds like A and has a nasal quality, as in this example, egophony is present, suggesting underlying consolidation of lung tissue. Finally, ask the patient to whisper 1, 2, 3.
1, 2, 3.
When these sounds are louder and clearer than normal, as in this example, whispered pectoriloquy is present. All these changes in voice sound suggest that the air-filled lung has become airless.
Okay, I'm going to examine your chest. Breathe normally for me.
To examine the anterior thorax, have the patient lie supine and breathe normally. Observe the condition of the skin and inspect the chest for deformities, asymmetry, and respiratory movement. Next, palpate the chest to locate any areas of tenderness or to assess any lesions or abnormalities. Then, assess respiratory excursion. Place your thumbs along each costal margin with your hands along the lateral rib cage. Raise loose skin folds between your thumbs and ask the patient to take a deep breath.
Take a deep breath in, please, and exhale completely. One more time.
Observe the displacement of your thumbs and feel for the range and symmetry of movement as the patient exhales fully. Next, palpate for tactile fremitus.
Say 99.
As the patient repeats 99, compare symmetrical areas. Using the edge of the hand to detect vibrations is also common. Because fremitus is difficult to feel through the breast tissue of women, in those cases, you may need to gently displace the breast. Next, percuss the anterior thorax in symmetrical areas, proceeding from the supraclavicular area down to the sixth rib or below. Again, compare both sides. Identify your percussion notes and their locations. You should hear resonance over the anterior lung fields. If you want to check the level of the right diaphragm anteriorly, percuss from resonant lung downward to liver dullness. To auscultate the anterior chest, take the same systematic approach you just used for percussing the posterior chest. Listen to the duration, pitch, and intensity of the inspiratory and expiratory sounds. Decide what type of breath sounds you are hearing, and note any added sounds. If you hear heart sounds near the heart, try to ignore them while you concentrate on the breath sounds.
99 repeatedly.
99. 99. 99. 99.
If you hear bronchial or bronchovesicular breath sounds where they should not be, listen for transmitted voice sounds. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include a combination of language and charting. For example, thorax is symmetric with good expansion. Lungs resonant. Breath sounds vesicular, no ralls, wheezes, or rhonchi. Diaphragms descend 4 centimeters bilaterally. To summarize, examination of the thorax and lungs includes inspection, palpation, percussion, and auscultation of the posterior and anterior thorax.